Welcome back to the Deep Dive. I'm so glad you could join us today because we are about to tackle a subject that honestly feels like it belongs in a different era.
It really does.
Maybe even a different world. We're talking about a disease that, has been written about in ancient scrolls, it's been feared in medieval villages, and yet here it is, sitting right here, right now, in our modern medical textbooks, and more importantly, in active clinics. We are talking about Hansen's disease, the condition that for most of history was known as leprosy.
It is great to be back. And you're absolutely right about that ancient yet modern dichotomy. It's one of the most fascinating and frankly challenging things about this entire topic.
How so?
Well, you have a disease that carries literally thousands of years of stigma and mythology. I mean, the word itself is heavy. But then when you strip all of that away and you look at the pure science, the immunology, the public health policy, the clinical reasoning, it's incredibly sophisticated.
Right.
It's this perfect storm, really, of biology and sociology.
A perfect storm. I like that. And the way we're going to explore this perfect storm today is by doing something a little bit different. We aren't just going to lecture you on the disease from start to finish.
Which can get a little dry.
It can. So instead, we're going to anchor our entire conversation around a single high-stakes question. I want you to think of it as a medical mystery that, it also doubles as a board exam nightmare.
I love this approach. I really do. Because in medicine, especially on these big exams, the questions they ask aren't just trivia. They're not trying to see if you memorized a random fact.
No, it's deeper than that.
It's so much deeper. They are designed to test if you understand the system. They want to know if you can navigate the complexities of the human body and at the same time the complexities of the healthcare system. It's a dual challenge.
So here's the mission for today's deep dive. We're going to dissect this question. We're going to take it apart piece by piece. We want to understand not just which answer is correct, but more importantly, why the other answers are wrong.
Because the wrong answers, the distractors, are where so much of the learning happens. They expose the common pitfalls.
Exactly. And what that tells us about how to actually treat a patient in the real world. We've got a stack of sources here, guidelines from the Ministry of Health, some notes on immunology, clinical protocols. We're ready to go.
And we're going to get into the weeds. We'll go deep into the pathophysiology, which is really just the mechanism of the disease. How does it actually work? We'll look at the legal requirements, the bureaucracy. We'll look at the pharmacology, the drugs. By the end of this hour, you are going to understand Hansen's disease on a level you never thought possible.
Let's set the scene. Imagine you're a doctor. You've been studying for years. You are sitting in that quiet, intensely stressful exam room. You've got your number 2 pencil. Your heart is pounding a little bit. You flip the page and you see this question. I'm going to read it verbatim so you can play along at home.
Okay, I'm ready. My palms are already sweating.
The subject is, identify the correct statement regarding Hansen's disease. Pretty straightforward. Here are your options. Option A, in the presence of erythema nodosum leprosum, the Mitsuda test is positive. Option B, like American tegumentary leishmaniasis, Hansen's disease is a disease of compulsory notification. Option C, prednisone is the drug of choice for type 1 and type 2 reactions, regardless of intensity. And option D, in cases of Hansen's and tuberculosis co-infection, the standard multibacillary Hansen's treatment scheme, and that means the same drugs and doses, should be followed.
Wow, just hearing that read aloud brings back memories of some very long nights in the library. It is such a classic trap question.
It really is, isn't it? It looks innocent enough on the surface, but every single one of those options is loaded with nuance. It's a minefield.
A total minefield. Option A throwing these heavy, very specific immunology terms at you. Then option B suddenly pivots to like bureaucracy and public health law.
Yeah, a total left turn.
Then option C is all about drugs, pharmacology. And option D presents this incredibly complex clinical scenario of a patient with 2 major infectious diseases at the same time.
So before we reveal the answer, what's your gut check on this? What is the examiner actually trying to test with a question like this? What's the bigger picture?
I think this question is brilliant, and I use that word intentionally because it tests what I would call the intersectionality of medicine. It's not enough to be a good dermatologist and recognize a skin lesion.
Right.
It's not enough to be a good pathologist and know what the bacteria looks like under a microscope. The examiner here wants to know, do you understand the public health laws that govern our unified health system, the SUS?
The administrative side.
The administrative side, which is critical. Do you understand the specific and very different immune mechanisms that drive the reactions in this disease? And practically, do you know how to manage a patient who is unlucky enough to have both tuberculosis and Hansen's at the same time? It tests if you are ready to be a complete physician, not just a specialist in one narrow field.
It's testing that so what factor. It's asking, okay, you know the science, but can you apply it in a real messy human context?
That's it, exactly.
All right, let's not keep everyone in suspense any longer. We have reviewed the source material, we've double-checked the guidelines, and the correct answer is option B.
Like American tegumentary leishmaniasis. Hansen's disease is a disease of compulsory notification.
Oh.
That is our winner.
Now, I have to admit, when I first saw that, my first reaction was, really? The paperwork option.
I get that.
It feels a little, anticlimactic, especially compared to the dramatic immunology and pharmacology and the other choices. So why is this the seemingly bureaucratic point the most important and correct takeaway here?
It might seem dry on the surface, but let's unpack why option B is actually the cornerstone of the entire public health strategy for this disease. We are dealing with a concept called compulsory notification. In the world of public health, this isn't just a suggestion. It's a very specific legal and sanitary concept. Both Hansen's disease and American tegumentary leishmaniasis fall into a category of endemic diseases that have a massive potential for causing physical disability and huge socioeconomic impact.
So when you say endemic, just to be clear, you mean they are regularly found within the population, right? They aren't just like rare visitors, they live here.
Exactly, they are a constant presence. And Brazil, it's important to note, has one of the highest burdens of Hansen's disease in the entire world, second only to India. It's a major, major public health issue here.
So the stakes are high.
Incredibly high. And because these diseases can cause permanent, devastating deformities, we're talking blindness, the loss of function in hands or feet, the government has a very vested interest in tracking every single case. The rule itself comes directly from the Ministry of Health, specifically Portaria No. 204 from 2016. It's black and white. It states that if you even suspect a case, let alone confirm it, you are legally obligated to report it to the health authorities.
So this isn't just about keeping a neat file in a clinic store somewhere. This is about feeding a larger system.
Precisely. You've hit the nail on the head. It's what our sources call an administrative sanitary fact. When a doctor fills out that notification form, it doesn't just go into a folder. It gets entered into CNN, the information system for notifiable diseases. CNAN. And you can think of CNAN as the central nervous system, the brain of our public health system.
And why is feeding that brain, feeding CNAN, so critical for the individual patient standing in front of you?
This is the most important part, because the treatment for Hansen's disease, the specific multi-drug therapy, which we call PQT or polychemotherapy, is not sold in commercial pharmacies.
Oh, I did not know that.
You cannot walk into a drugstore with a prescription and buy it. It is provided exclusively and completely free of charge by the government.
So the government controls the supply chain 100%.
100%. So think about the logic. If the government doesn't know a patient exists because their case wasn't notified and entered into CNAN, then the medication is not allocated for them. The supply chain breaks down before it even starts.
Wow.
The notification is the key. It's the trigger that releases the cure from the government stockpile to the local clinic for that specific person.
That reframes option B completely. It's not just paperwork. It is literally the key to the medicine cabinet.
It is. And there's a second, equally important reason for notification. Hansen's is an infectious disease, right?
Right.
So if you find one case, you have to assume there might be others nearby, especially within the household. Notification automatically triggers a process called contact tracing.
So the public health team gets involved.
Yes. The local health team goes to the patient's house. They examine their family, their children, their spouse, anyone living in close quarters. You have to find the source of the infection and check for other cases to break the chain of transmission. You can't do any of that if the case remains a secret between the doctor and the patient.
And the question specifically links Hansen's with American tegumentary leishmaniasis. Why that comparison? Is there a biological link?
It's not so much a biological link as it is a social and political one. You could call them brothers in neglect.
Brothers in neglect.
They're both classified as neglected tropical diseases. They both primarily affect the skin. They both can cause serious disfigurement, and they both thrive in areas of poverty, poor sanitation, and overcrowding. So by grouping them together, the exam question is flagging for the test taker that these are diseases of national interest that require strict state surveillance to control.
Okay, so we've thoroughly established why option B is correct. The administrative side of medicine is, in this case, just as life or death as the biological side. But our source material has this fantastic phrase I want to get to. The clinic is sovereign. I love that.
It's a classic medical maxim, a guiding principle. It means that no matter what the fancy lab test or imaging scans say, what you see, what you hear, and what you feel from the patient in front of you, that is the ultimate truth.
So let's leave the paperwork in the public health system for a moment and step into the clinic. To really understand why the other options A, C, and D are so dangerously wrong, we need to understand the beast itself. Let's do a Hansen's disease 101. At a fundamental level, what is happening inside the body?
Okay, so fundamentally, Hansen's disease is a chronic infectious disease, and it's caused by a very specific bacterium called Mycobacterium leprae.
Mycobacterium. I mentioned this earlier. That name implies it's related to tuberculosis, right? Mycobacterium tuberculosis.
Correct. They are biological cousins, first cousins even. And under a microscope, they look remarkably similar. They're both what we call acid-fast bacilli.
What does that mean, acid-fast?
It's a staining property in the lab.
Yeah.
It means they hold on to a specific red dye, carboxyl, even when you try to wash them with a strong acid. They're stubborn. And that stubbornness gives us a clue about their resilience. But M. leprae has a very specific and kind of bizarre personality.
A personality?
Yes. For starters, it's an obligate intracellular parasite.
Break that down.
Obligate intracellular means it has to live inside a host cell. It can't survive on its own for long out in the world. It's completely dependent on our cell's machinery to replicate. It's a total home invader.
And it's picky about which homes it invades.
Extremely picky. It has what we call a tropism, a fatal attraction, for two specific types of cells in the human body. The first are macrophages.
Okay, those are the big eater cells of the immune system, the cleanup crew.
Exactly. And it's pretty clever of the bacterium to hide out inside the very cell that's supposed to kill it. But its true love, its primary target, is the Schwann cell.
And Schwann cells, those are in the nervous system.
Yes. This is the absolute key to understanding the entire disease. Imagine your nerves are like electrical wires carrying signals from your brain to your hand. The Schwann cells are the rubber insulation, the plastic coating wrapped around that wire.
Okay.
They protect the nerve, and just as importantly, they help the electrical signal travel incredibly fast. They're vital.
And this bacteria, M. leprae, decides to move into the insulation.
Precisely. It infects the Schwann cells. And this is the central tragedy of Hansen's disease. The body's immune system, of course, recognizes that there's an intruder inside the Schwann cell, and it launches an attack.
As it should.
As it should. But in the crossfire of that battle, the insulation, the Schwann cell, is destroyed. And eventually, the wire itself, the nerve axon, is permanently damaged.
So the nerve damage isn't just the bacteria chewing on the nerve, it's actually the body's own attempt to fight the bacteria that causes most of the destruction.
That is it. You've just described an immunopathological disease. The immune response itself is the primary driver of the pathology of the damage.
That's fascinating and terrible at the same time. Let's talk about transmission. I think there is so much fear and misinformation associated with this. People think if they just touch someone with Hansen's, they're doomed.
That is myth number one, and it's a myth we need to bust right now, loud and clear. Transmission is person to person, yes. It happens via the upper airways. So respiratory droplets from sneezing, coughing, similar to how the flu or COVID spreads. But, and this is a huge but, the infectivity is incredibly low. It is not a very contagious disease.
So I can't get it from shaking hands or sitting next to someone on a bus.
Absolutely not. You can't get it from a casual interaction. You can't get it from sharing a meal. Transmission requires prolonged, intimate, close contact over a long period. We're talking about living in the same household, often in overcrowded conditions for months or even years, with someone who has the untreated high bacterial load form of the disease.
And on top of that, isn't it true that most of us are naturally immune anyway?
Yes. Another critical point. It's estimated that about 90 to 95% of the entire human population has a natural genetic resistance to M. leprae.
95%.
So if you or I were exposed to the bacteria, our immune systems would most likely recognize it, clear it immediately, and we would never even know we were exposed. It is only that small 5 to 10% of people who are susceptible to developing the clinical disease.
That is really, really reassuring. But for that small percentage who are susceptible, what does the disease actually look like? If I'm a patient walking into your clinic, what are the classic signs you're looking for?
The hallmark of Hansen's disease, the absolute classic presentation, is dermatological, skin plus nerves. It's a package deal.
Okay, so let's start with the skin. What do you see?
On the skin, you see spots, lesions. They can be lighter than your normal skin tone, what we call hypochromic, or they can be reddish, erythematous, or even brownish. But lots of things cause spots on the skin.
Right, fungal infections, eczema.
Exactly. So the spot itself isn't enough. The thing that should make a siren go off in a clinician's head is the alteration of sensitivity within that spot.
The feeling is gone.
Feeling's gone, or at least diminished. It usually follows a very specific progression. The first sensation to go is thermal sensation. The patient can't tell the difference between hot and cold on that specific patch of skin.
So they might burn themselves and not realize it.
Precisely. After thermal, you lose pain sensation, what we call dolorosa. And finally, you lose tactile sensation, the feeling of light touch.
That loss of pain sensation, it sounds almost like a superpower, but in reality, it's unbelievably dangerous.
It's the most dangerous part of the disease. Pain is a gift. It's our body's alarm system. It tells us when we are being hurt, when tissue is being damaged. A patient with Hansen's might pick up a scalding hot coffee pot and not flinch. They might get a cut on their foot or step on a nail and keep walking on it all day because they feel nothing.
And because they don't feel it, the injury goes untreated.
Exactly. The wound gets worse, it gets infected, the infection can go deep into the bone, and that is how you get the severe deformities and the eventual need for amputations. It's critical to understand it's not the bacteria eating the fingers and toes away, it's the accumulation of unfelt, untreated trauma over years.
A devastating cascade. And what about the nerves themselves? Can you actually feel the damage?
Yes, absolutely. This is a key part of the physical exam. We palpate or feel the major peripheral nerve trunks. Because of all that inflammation happening inside and around the Schwann cells, the nerves get thick and hard.
Like a rope.
Exactly, like a thick, hard cord under the skin. the ulnar nerve at the elbow, the funny bone, the great auricular nerve in the neck, the posterior tibial nerve in the ankle. When you feel a thick and tender nerve, that's a huge red flag.
So just to summarize the clinical picture, you have skin spots, you have a loss of sensation in those spots, and you have thickened peripheral nerves. That's the classic triad.
That is the sovereign clinic. If you have those signs, especially in an endemic area like Brazil, you have a very high suspicion for Hansen's disease.
Okay, now that we have that solid foundation, let's use this knowledge to go back and dismantle the other options in our exam question. Let's start with option A.
I'm ready.
Option A states, in the presence of erythema nodosum leprosum, the Mitsuda test is positive. Now, to the untrained ear, that just sounds very scientific and plausible. Why is it a trap?
This is what I like to call the Mitsuda paradox. It's a beautiful trap because it tests a deep understanding of the immunology. To see why it's wrong, we have to first explain what the Mitsuda test actually is, and more importantly, what it is not.
Okay, so first off, is it a diagnostic test? Does a positive Mitsuda test tell you, yes, you have Hansen's disease?
No, absolutely not. And that is the single biggest misconception about this test. The Mitsuda test is prognostic, not diagnostic.
Prognostic, so it tells you about the future course of the disease.
In a way, yes. It's an evaluation of your immune system's capability. It asks the question, if this person has to fight the M. leprobacteria, what kind of army do they have? Are they sending in a well-trained special forces unit, or are they sending in a disorganized militia?
I like that analogy, so it's assessing the quality of the troops.
Exactly. We inject a little bit of heat-killed M. leprae protein under the skin and wait a few weeks to see what happens. A positive Mitsuda test, which means you get a big red lump, tells us you have a strong cellular immune response. Your T cells are aggressive. They're capable of building a strong wall granuloma around the bacteria and containing it effectively.
So strong wall, positive test.
Right. And this strong cellular response correlates with the milder, contained paucibacillary form of the disease, which is called the tuberculoid form.
Okay, makes sense. So what does a negative test mean?
A negative Mitsuda test, where you get little or no reaction, means your cellular immunity against this specific bug is weak, inefficient, or completely absent. Your body cannot build that containing wall. The bacteria are free to multiply and spread uncontrollably throughout your body.
So the militia showed up.
The militia showed up, and they're not doing a very good job. And this weak or absent cellular immunity correlates with a severe, disseminated, multibacillary form of the disease called the Virchowiana form, also known as lepromatous-leprosy.
So just to be sure I have it, negative Mitsuda equals a void of immunity, which equals severe disease.
Perfect. Our source material gives a great mnemonic for this. V for Virchowiana equals V for void of immunity equals Mitsuda negative.
Okay, I'll remember that. Now let's connect that back to the first part of option A, the condition called erythema nodosum leprosum, or ENL. What is that?
ENL is a specific type of immune reaction in Hansen's disease. We call it a type 2 reaction. And crucially, ENL is a humoral response. It's driven by antibodies and immune complexes that get deposited in the tissues, causing a massive systemic inflammation. It's a very painful, very serious condition.
Okay, I think I see the contradiction starting to form here.
You're on the right track. Here's the key. To get ENL, to have this massive reaction driven by immune complexes, you first need something for the antibodies to bind to. You need a huge amount of bacterial antigen floating around your system.
So you need a high bacterial load.
You need a very high bacterial load, which means, by definition, ENL occurs almost exclusively in patients with a severe Virchowiana form of the disease.
The ones who couldn't build the wall.
Exactly. So let's connect the dots. If a patient has ENL, they must have a high bacterial load. If they have a high bacterial load, they must be a Virchowiana patient. If they're a Virchowiana patient, their cellular immunity is, by definition, void. Therefore, their Mitsuda test must be
negative.
Bingo. Option A claims the Mitsuda test is positive in the presence of ENL. That is a biological contradiction. It is impossible in this context.
That is such a beautiful piece of clinical logic. It's not about just memorizing a random fact. It's about deriving the answer from the fundamental mechanism of the disease.
That's how you have to approach these questions. You can't just memorize. You have to understand the why.
I love it. Okay, let's move on to the next trap, option C. This one is about treatment. Prednisone is the drug of choice for type 1 and type 2 reactions, regardless of intensity. Now, prednisone is a powerful steroid. It crushes inflammation. This sounds plausible. Why isn't it the right answer?
This option fails because it's a dangerous oversimplification. It tries to apply a one-size-fits-all solution to something that requires incredible nuance. As we just touched on, there are two main types of immune reactions in Hansen's, and they are driven by completely different parts of the immune system.
Okay, let's break them down clearly. Type 1 versus type 2.
Okay, type 1 is called the reverse reaction. This happens when the patient's cellular immunity, their T cells, suddenly wakes up or gets stronger. This often happens after you start treatment. The immune system suddenly says, wait a minute, there's an invader in these nerves I didn't see before, and it launches a furious inflammatory attack on the nerves and skin lesions.
So it's an upgrade in immunity that paradoxically makes things worse for a while.
Exactly. It's a delayed type hypersensitivity reaction. And because this is a T cell cellular mediated process, corticosteroids like prednisone are the absolute drug of choice. They calm down those overactive T cells. So for the type 1 part of the statement, it's actually correct.
But the option includes type 2 as well.
Right. And that's where it falls apart. Type 2 is the erythema nodosum leprosum, the ENL that we just discussed. This is a humoral response. It's about immune complexes, neutrophils, and a massive, massive release of a pro-inflammatory chemical called TNF-alpha.
So a totally different mechanism.
Completely different. Yep. And what prednisone can help dampen the inflammation a bit, the absolute drug of choice, the gold standard treatment for type 2 reactions, is a drug called thalidomide.
Thalidomide. Now that is a name with a very heavy history. Most people associate it with the terrible birth defects in the 1950s and 60s.
Yes, and that history is real and tragic. It is a potent teratogen, meaning it causes severe birth defects, and it can never be used in women who are or could become pregnant. But in the very specific context of type 2 Hansen's reactions in men, or in women who are postmenopausal or have had a hysterectomy, it is a miracle drug.
What does it do?
It is a powerful inhibitor of TNF-alpha. It essentially shuts down the engine driving that specific type of inflammation incredibly effectively. It's far superior to prednisone for controlling ENL.
So you simply cannot have a blanket prescription of prednisone for both. If it's a type 2 reaction, your first thought should be thalidomide.
That's the standard of care. Prednisone's a backup for type 2. We'll use it if the patient is a woman of childbearing potential, since she can't take thalidomide, or if the reaction has specific severe complications like nerve inflammation neuritis or testicular inflammation orchitis. But the drug of choice implies the first and best tool for the job, and for uncomplicated ENL, that tool is thalidomide.
And that phrase in the option, regardless of intensity, that's another one of those red flag absolute terms, isn't it?
Huge red flag. In medicine, intensity always matters. A mild reaction might just need observation, while a severe one needs aggressive intervention. Right. Absolutes are almost always wrong on these exams.
That's a great tip. All right, let's look at our final distractor, the very tricky option D. It says, in cases of Hansen's and tuberculosis co-infection, the standard multibacillary Hansen's treatment scheme, same drugs and doses, should be followed. This sounds like the path of least resistance. You've got a kit for Hansen's, just use it. Why is this so dangerous?
This is, without exaggeration, a potentially lethal trap. It tests a critical understanding of pharmacology and the behavior of these two related but very different bacteria.
Okay, so what's the core of the problem?
The core of the problem is a single drug that is used to treat both diseases, a powerful antibiotic called rifampicin.
Okay, so if the drug works for both Hansen's and TB, why can't we just use the Hansen's regimen? It seems efficient.
It all comes down to the dosing and the frequency. In the standard Hansen's PQT blister pack for multibacillary patients, you take a supervised dose of 600 milligrams of rifampicin once a month.
Once a month, okay.
In the standard treatment for active tuberculosis, you take rifampicin every single day.
Ooh, wow. Okay, that is a massive difference. 1 dose a month versus 30 doses a month.
It's a gigantic difference. And here's why it matters. Tuberculosis is a much more aggressive, faster replicating infection, usually in the lungs. If you treat a patient who has active TB using the Hansen's dosing schedule, giving them rifampicin just once a month, you are essentially underdosing their TB by a factor of 30.
It's like trying to put out a forest fire with a single bucket of water once a month.
It's even worse than that. You're not just failing to kill the TB bacteria, you are actively teaching them how to survive the drug. You are selecting for the toughest bacteria and breeding antibiotic resistance.
Yeah, that's the nightmare scenario.
It is the absolute nightmare scenario. You risk creating multi-drug resistant tuberculosis or MDR-TB, which is incredibly difficult to treat, toxic, expensive, and a global public health crisis.
So what is the correct protocol? What is the rule? If a patient has both of these diseases, who wins? Which treatment takes priority?
TB is the boss. Tuberculosis is the more acute, life-threatening illness. It kills much faster than Hansen's disease. Therefore, the TB regimen takes absolute priority. You must give the daily rifampicin to effectively treat the TB. You then adjust the Hansen's regimen to accommodate the TB drugs, often by just continuing the other Hansen's medications, like dapsone and clofazimine, alongside the full TB treatment. But you absolutely, under those circumstances, can just use the standard Hansen's kit.
That is crystal clear. You have to treat the most immediate and dangerous threat first and most aggressively.
Always.
So we have now systematically dismantled the entire question. We know why B is right, and we know in detail why A, C, and D are dangerously wrong. I want to shift gears for a minute, though. We've been very academic, but let's talk about the practical side of diagnosis. Our outline mentions the diagnostic approach. If a listener is a healthcare student, or you're just curious, how do you actually make the diagnosis in the clinic?
Well, as we've been saying, the clinical exam is sovereign. The suspicion starts with what you see and what the patient tells you. But there are some specific tools we use to confirm it.
What's the most basic one?
The most basic is the sensitivity test. It's incredibly low-tech, but incredibly effective. You take a wisp of cotton, and you lightly touch the center of the skin lesion. Then you touch a corresponding area of normal skin on the other side of the body. You ask the patient, with their eyes closed, does this feel the same or different?
Simple as that.
Simple as that. You can do the same with a sharp and a dull object to test for pain. And for thermal sensation, you can use two test tubes, one filled with hot water, one with cold. Get the patient reliably tell them apart when you touch them to the lesion.
It's really amazing that in our age of AI and MRI scans, a piece of cotton and some warm water are still primary diagnostic tools for a major disease.
It really speaks to the fundamental neurological nature of the disease. But we do have some more modern help. Ultrasound of the peripheral nerves is becoming more and more important.
What does an ultrasound show you that your fingers can't?
It allows us to look inside the arm or leg and see the nerve trunk itself. We can measure its exact thickness and see if it's swollen or if there's fluid and edema around it, sometimes long before our fingers can even feel that thickening. It helps us catch the nerve damage much earlier.
Can it see information?
Yes. Using the Doppler function, we can see if there's increased blood flow to the nerve, which is a clear sign of active inflammation, what we call neuritis. This is critical for deciding when to start steroids to prevent permanent damage.
And what about looking for the bug itself? The microscope work, the bacilloscopy?
That's the skin smear. We make a tiny incision, usually on the earlobe or elbow, and take a small sample of tissue fluid. We smear it on a slide, use that acid-fast stain we talked about, and look under the microscope for the little red rods of M. leprae.
And if you see them, you're done. Diagnosis confirmed.
If we see them, yes, it confirms the diagnosis, and it also tells us it's the multibacillary form, which requires longer treatment. But here is the crucial catch. If we don't see them, it does not rule out the disease.
Really? A negative test doesn't mean you're in the clear.
No. In the possibacillary form, the milder tuberculoid type, there are so few bacteria in the body that the chances of finding one in a tiny skin smear are very low. But the patient still has the skin lesions, they still have the nerve damage.
So the clinic is sovereign?
The clinic is sovereign. If the cardinal signs are there, the lesion with sensory loss, the thickened nerve, you make the diagnosis and you start treatment. Even if the skin smear is negative, you trust what you see.
Before we wrap up, let's take a moment to touch on the history. Section 7 of our source material is titled Worthy of a Nobel. I think it's so important to connect the science we use today to the people whose breakthroughs made it all possible. We have 3 names here: Hansen, Koch, and Tuyu.
It's a lineage of scientific giants, and their stories are intertwined. Let's start with the man who gave the disease its modern name, Gerhard Armauer Hansen.
Okay.
He was a Norwegian physician, and in 1873 in Bergen, he was the first person to identify Mycobacterium leprae in the tissues of patients. This was a monumental paradigm shift.
Why was it so important? It seems simple now, finding a germ.
Because before Hansen, leprosy was not understood as an infection. It was considered a curse from God, a result of bad air or miasma, or most damagingly, a hereditary taint that ran in families.
So it was a moral failing, not a medical condition.
Exactly, a source of immense shame.
All right, let's get right into it.
Hansen proved it was an infectious disease. He moved it from the realm of religion and superstition firmly into the realm of biology, and that is always the first essential step toward finding a cure.
Then we have Robert Koch.
The father of modern bacteriology. He won the Nobel Prize in 1905 for discovering the tuberculosis bacillus. The connection is direct. Because M. leprae and M. tuberculosis are cousins, Koch's pioneering techniques for staining and identifying these acid-fast bugs were the exact toolkit that made Hansen's work possible. They are scientifically and historically linked.
And finally, a much more recent name, Tuyu.
Yes, she won the Nobel Prize in 2015 for her discovery of artemisinin, a revolutionary treatment for malaria.
So what's the connection to Hansen's?
The connection here is the category. Neglected tropical diseases, malaria, leishmaniasis, and Hansen's disease all fall into this bucket. These are diseases that primarily affect the poorest people in developing nations. For centuries, they didn't receive the research funding or attention that diseases of the developed world did. Her Nobel was a powerful signal from the scientific community that research into these diseases is just as scientifically valid and humanitarianly urgent as research into cancer or heart disease.
It connects right back to our correct answer, option B. These diseases need special attention, special notification systems, and special champions precisely because the commercial market doesn't always prioritize them.
That is the perfect summary of the connection.
We have covered a massive amount of ground today, from the Cyanine database to the Schwann cells, from the nuances of thalidomide to the Nobel Prize. Let's do a rapid-fire summary for our listeners. What are the absolute key takeaways from this deep dive?
Okay, here we go. 1. Notification is mandatory. Hansen's is a disease of compulsory notification. You must report it to Cyanine to trigger the supply for your medication and to initiate contact tracing. It's the key that starts the engine. 2. Mitsuda is prognostic, not diagnostic. It measures your cellular immunity. In severe Fortroiana cases, your cellular immunity is void, so the Mitsuda test will be negative. 3. Know your reactions. They're not the same. Type 1, the reverse reaction is cellular, and its drug of choice is prednisone. Type 2, erythema nodosum is humoral, and its drug of choice is thalidomide, unless contraindicated. And 4, the co-infection hierarchy. TB is the boss. If a patient has both TB and Hansen's, you must prioritize the daily rifampicin regimen for TB to prevent the development of drug resistance.
Perfect. A clear, concise roadmap. I want to leave you, our listener, with one final provocative thought to mull over. We have spent the last hour talking about the science. We have an effective cure. The PQT multi-drug therapy is effective and it's free. We have reliable diagnostic methods. We have sophisticated notification systems. So my question is this: why does this disease still exist? Why are we still seeing thousands of new cases every year in places like Brazil?
That is the ultimate question, isn't it? We talk about the goal of elimination, but in reality, the persistence of Hansen's disease today is likely less a biological problem and more a symptom of deep-seated social factors,
Such as
overcrowding, poor housing, lack of sanitation, malnutrition, and perhaps most powerfully, the ancient stigma that still prevents people from coming forward and seeking help early when the disease is most treatable and before the damage is done.
It seems the final frontier in the fight against Hansen's isn't biological at all, it's social. The bacteria hides in the cracks of our society just as effectively as it hides inside our cells.
I couldn't agree more. The science is largely done. The social and public health work continues.
On that thoughtful note, thank you so much for joining us on this deep dive. Keep asking questions, keep looking for the why behind the what, and always remember the clinic is sovereign.
See you next time.